Okay, so why did we create the Rapid Rehabilitation Framework? Um, Look, I suppose there's loads of reasons why, but there's a right and a wrong way to do things. Is the first thing, and I suppose over 10, 15 years worth of experience, you kind of develop a consistent structure in what you're doing, and the framework is to try and put that out clearly, set it out clearly, to provide a structure to hold ourselves accountable, to make sure that what we do is we go through a full and thorough, comprehensive progression of rehabilitation, but also to be able to make sure that we have a continuity amongst our team, and then also to be able to explain clearly the plan and the structure for our clients when they come in, that we can say, look, here's where we are today on the roadmap. Here is level 2, here's level 3, and show that there's a plan in place here. And it's also not to be overly prescriptive, because we know we then have to apply it to the individual. So it's a framework. It's not a paint by numbers. It's an outline. It's a plan, making sure that we have a North Star to kind of guide us along the journey. And I think that's really the main reason why, it gives us that sense of a target and an expectation.
Yeah, and I mean, it was something we were both doing anyway. We just didn't have, I suppose, a clear definition on it or a clear name on it. There was little things I was doing, little things you were doing. We're like, actually, you know what, let's sit down here. Let's graph it all out. Let's imagine it was a knee injury. Let's imagine it was a shoulder injury. What are the common trends? Obviously we know the diagnosis. What are the common trends around activation or rehab? When is it strength? When is it power? What does sport look like? How does that change from joint to joint? And having this sort of overbearing idea of like, can we apply this now to multiple joints, multiple age groups, multiple sports, and having that framework. And we all know patients, I suppose, who've come into us and they're trying to work on level 5 and they haven't nailed maybe level 1 or 2 yet, or vice versa. People who nail 1, they nail 2 and they jump to 5 and they skip 3 or 4. That education piece, it is invaluable. And you can even see it with members or with patients when we explain that to them, that you're looking really, really strong here. Your calf strength is unbelievable, but you can't hop. If you can't hop, how do you expect to sprint?
Yeah.
And if you can't sprint, how do you expect to play a full match or 2 matches in a week? So that education side, showing that to them on the pyramid, telling them how, someone's gone wrong in the past by doing this, or, explaining why they've gone wrong in the past, maybe why rehab has failed them up to now, they've skipped a step, and it's a light bulb moment for them.
Yeah, 100%. And I think the visual of a pyramid structure kind of works really well, because you have to have that kind of wide and stable base, the foundations in the early stages. And that wide and stable base allows you to build this high peak ultimately. So I think that can be a nice reference. And the idea of the pyramid structure is also that, you can't achieve the higher levels until you have nailed the bottom levels. And if I'm ever struggling in those higher levels, it's always because I'm missing something down lower. Have we got our diagnosis right? Have we built enough strength, enough range of motion, enough control for us then to be able to go into those higher levels? So it's always a nice way to circle back then again, to hold ourselves accountable, to make sure that have we got this person good enough at the foundations to then be able to jump, land, hop, skip, or climb the stairs or play golf or whatever it might be. And I think it just provides that nice structure.
And sometimes it's not exciting as either, because, the level 5 stuff, the top of the pyramid looks great. On Instagram, that's brilliant. To the patient, I'm doing this really exciting drill, or I use golfers as the example. They've got the super speed sticks and they're swinging for the hills, but actually they don't rotate well in the first place, or they can barely do a squat or barely do a hinge. So they're skipping so many levels and doing the really fun, really exciting thing, when it's actually the boring, slow, simple, basic thing that they're missing. So as you said, if you haven't ticked the bottom level, you have no right kind of jumping to the top.
Yeah, 100%. So, okay. In terms then of, maybe we'll have a little bit of a chat through what our different levels are. So I suppose our first level is D for diagnosis. And look, this is just a fundamental part of, I suppose, of what we do as physiotherapists, and it really sets the scene. And I think getting an accurate diagnosis is just absolutely vital. And what it does is it then sets us up to make sure that everything else that follows is done correctly. So based on our diagnosis, we can then decide what level of activity should we be doing, how heavy should our load be, how many exercises are we doing, what type of exercises are we doing, and we all build from there, and to make sure that what we don't do is underload somebody by taking it too easy, or overload somebody by pushing them harder than they should.
And what are some of those elements of an accurate diagnosis? Like, if I come into you and I've got a problem, be it my knee or my shoulder, what are you doing to diagnose me?
Yeah, the first thing starts with a clinical assessment and a history. And I suppose initially the history is always the most important thing. So we want to have a detailed conversation with you to understand fully what's going on, what's the pattern of this injury, when did it start, was there any incident, or was it more an overload problem? And we want to learn kind of the full background there, so that we can then make a kind of a hypothesis in our head as to what does this injury sound like? What do we think's going on? Do we think muscle is involved? Do we think tendon's involved? Do we think bone is involved? And from there then, after our detailed conversation, and we've got that full background, including what the patient's goals are, and what the level of activity they are currently able for, and what's aggravating their pain and their own perception of the injury. And once we have all of that stuff, we can then go ahead and do our clinical assessment, which is a kind of a step-by-step process where we'll usually first have a look at general movement, see, how is this person able to do basic tasks like a squat on 2 legs or 1 leg? What's their gait like? How are they doing functional tasks like climbing the stairs or bending down to pick something up, depending on their specific injury? Or it could be having a look at their golf swing, or it could be having a look at their weightlifting technique.
Yeah, their range of motion, their strengths. Is this a one joint problem? Is this, I hurt my shoulder lifting something over my head, or I was sprinting yesterday and I hurt my hamstring. Sometimes it's very quick and easy and simple. Like, okay, it looks like a hamstring strain, it smells like one. And other times, I suppose, it can be really complex. This is, I've had a sore back here for 2.5 years. I've had 4 MRIs, 3 X-rays. I've seen 7 specialists, and I'm not sure what's going on. So, that diagnosis can be really quick and easy. It can take a long time, and sometimes we do need to go and get an X-ray or get an MRI or see someone else. And I often think as well with the diagnosis, sometimes it is, everyone wants a one-word answer. Everyone wants hip or back or ligament or tendon. And sometimes it is a one-word answer, and sometimes it's not. Sometimes it's, well, do you know what, there's a few factors here that are playing a part. With your back pain, it's a little bit because of this, and this, and let's go after those maybe modifiable factors. So, to get to that really accurate diagnosis, it can take a little bit of work.
Yeah, and I think there's 2 ways to look at it, and I'll often explain it this way to our clients when we're looking to make a diagnosis. We have our structural diagnosis, and then we have our functional diagnosis. And sometimes one is way more important than the other, okay? In the case of a structural diagnosis, structural diagnoses are really important, are ones that really change what we need to do, such as, have I a fracture? If I have a fracture, we have to allow that bone to heal. We have to pull back. But if I have something a little bit more non-specific, and maybe I just have some overloaded tissue, well, then the structure is less important. And what's really important then is the function. And to be honest, the function is always really important, because that's the thing that we can really modify and change, I suppose, with what we do. And we can be very detailed in looking at the structure, and we can also be very detailed in looking at the function. If we want to be detailed looking at structure, it'll often involve further investigations, X-rays, MRI scans, CT scans, ultrasound, and maybe onward referral to experts who can give us clear guidance on the structure. And then when it comes to the functional piece, that involves, as you mentioned earlier, looking at range of motion, looking at how well somebody controls their body when they move, having a look at their muscle strength, muscle control. And there's a huge amount of detail around that that I think is very person specific and sport specific. And that's what we will spend a huge amount of time on, I suppose, in that early phase. So that ideally at the end of that kind of initial session, we have learned the full background story about what's going on here and all the contributing factors.
Yeah.
We've decided whether or not we need to isolate any structural diagnosis here, and organised referrals and onward opinions from specialists if required. And then we've got a really clear understanding of what the functional diagnosis here, what are the deficits that this person has that are contributing to the problem.
How important is it that the person themselves knows leaving here what their diagnosis is, or what you're diagnosing them as, and what you think the plan forward for them is, be it their expected timelines, or be it what they need to focus on first, the elephant in the room, what they need to improve?
Yeah, look, I think it's probably the most important thing ultimately. There's no point in me having this clear sense in my head and the person is confused and the person feels lost and maybe the person is worried and fearful. So it's trying to make sure that along the journey, we're building a partnership here with our clients all the time. And it can't be a one-way street. So it has to be a case of us understanding it together. And I think when things are going really well, it's a journey of discovery. We're discovering what's going on, and while the client with us is also discovering what's going on, and we're learning together. And there's a two-way feedback there on that in regards to a conversation, but also in regards constantly during our assessment. As we assess your movement, as we assess your strength, how does that feel? Do you think that's important? Does that link to your problem? And those conversations that are back and forth are often the real detail here as to how we get buy-in and how we understand and the person understands. And I always think it's an important thing to go and check with okay, so tell me what you learned today, or tell me what your sense of what's going on is now.
Even this week, I had somebody on I think Monday or Tuesday, and I was crystal clear on what their biggest problem was. I think it was their third session, and we were clearly working on one thing. It was their knee extension strength, their quad. And when they came back and it was getting better, but it wasn't perfect, and they still had this one thing that was improving, not a little bit with to go. And I asked them, I go, what's the biggest thing they're working on? And they didn't have a clue. And I said, we've been through this. Think about what of everything. I pulled up their 3 programs to date, and I said, what are we working on all these programs? Oh, we're working on the, it wasn't a one-word answer. So I made sure leaving that appointment that they were crystal clear. And, we almost have to remind ourselves at times that we might think we said it, whether they've understood it, whether they can say it back to us. It's so important.
Absolutely. And I think we have to be humble in regard to the fact that we don't want to speak using jargon terms when we're dealing with our clients. And we also want to make sure that we do simplify it. And as you say, I think quite often we can maybe we can go into detail that sometimes can be lost. So it is important that we always bring it back to that simple idea of what are you taking from today, and what are the main goals, and what are the things you need to work on. And absolutely, Mike, I think it's something that clinicians, including ourselves, should always do, is double check the understanding. Are we on the same page here? Have we got that sense of shared understanding as to what's going on? Just one other thing on the diagnosis piece, I suppose, is that we have to also be, I think, understanding and I suppose humble in the fact that our clinical assessment can't always isolate structural injuries. And, while our clinical assessment is brilliant at creating a sense of what the functional problem is, the person's strength, the person's power, and also can get a good sense of what the structural injury is, it's not perfect at that. And a good example of this will be things like muscle strains, and it's something that I think has really evolved in physiotherapy practice over the last few years, where you rewind 10 years ago, a muscle strain was at best a grade 1 or grade 2 or grade 3. Now we have a totally different way of thinking about it. We now want to know what actual structure is injured here. Have we got muscle injured? Have we got tendon injured? What part of the tendon is injured? And we know that our clinical assessment techniques can't fully find that out. So we need to refer for imaging if we want to be very specific around that. And I think that's a really important part. Again, that we've probably all been caught thinking, oh, this looks like a low grade strain. And then, okay, we go and organise a scan and realise actually there's a tendon involvement here and it's higher grade. And that's because some of those injuries are just a little bit sneaky in the way they present. They can feel fine when I'm lying on the bed. They can feel fine when I'm walking around. And these are often the ones then that people get caught with, where, geez, everything felt grand when I was doing all of this slow, easy stuff in the gym and slow and easy stuff on the physio bed. And then actually I went back running, and even jogging was okay, but when I went to sprint, I got caught. And that's because we didn't have the diagnosis right. And I can only just think of a slightly separate example there recently, where I had a client coming in, he's a distance runner and had a history of, previous stress fractures, and came in to be saying, listen, I've pulled my calf. Really certain he's pulled his calf. Kind of, that's what it felt like. He's had a low grade calf strain before, and we assessed it. And listening to his story, he had ran on it, got some pain, gave it a week to rest, ran on it again, got pain again, and then he did some soft tissue work himself, like got the massage going out, and it was around his lateral calf, and that made him way worse. He was really sore after the soft tissue work. When I assessed him and we palpate through the area, he did actually have a low-grade calf strain, but he also had a fibular stress fracture. And it's so easy to miss these things because, he says it's a calf injury. It kind of looks and smells like a calf injury, but only when we really dig into it and, listen carefully to his story, and also pay close attention to where his pain is and how it feels when we palpate that bone. And then we follow that up with a scan. We realize this guy has a stress fracture. We actually have to pull back here, and we can't treat it in the way we would normally treat a calf injury. And like that saves huge time for people too, because like you just don't want to be the clinician who is, you know, bringing someone around the roundabout of this is a calf strain when actually it's a stress fracture. And it's so I think that again just explains that reason why it's so important for us to get the diagnosis right.
Big time. And I think as part of that diagnosis, part of that plan, sometimes we can have the one word answer there, which is stress fracture or calf strain. But really, we've all the factors that led to that. You know, I often call it finding the root cause. It's like, okay, you're coming into me with your 4th calf strain in a row. It's easy to just say, let's rehab the calf. But really, this could be a load management issue that you're doing far too much running. This could be a strength issue, you're not generally strength training. This could be an asymmetry issue that maybe your other leg is weak or your knee isn't doing its job. And when you're running, there's not enough coming from your quad, not enough from your glute, and it's all coming from your calf. This could be, I'm not sleeping, I'm not recovering, I'm not eating enough. And, you know, while we often want a one word, one joint, you know, simple answer, you know, I often say it's like a pie chart. And on that pie chart, we've got really big segments, you know, the elephant in the room. The huge thing here is, okay, your calf's at you. We've all these little contributing factors, they're all adding up. And, you know, the more I think we can think maybe holistically, or the more we can start to challenge some of these other things, or even just highlight them. You know, this might be new information to the runner who didn't know that they ramped their mileage too quickly after their holiday, or they didn't know that, you know, actually I need to sleep and eat more and whatever else it is. So there's all these factors that lead us to the injury. What's the root cause? I see it with my golfers all the time. Yeah. You know, they have a low back pain, and the golf low back pain from rotating can be completely different than the low back pain I get in the garden picking something up. Yeah. And, you know, it's a little bit my hip could be more mobile. It's a little bit my shoulder could be more mobile. It's a little bit I need to sit back, and it's a little bit that I shouldn't hit 150 balls on the driving range the day before round. So yeah, if you can get all these factors right, I think that's where you can get a huge win with patients. Yeah. And maybe, you know, earlier on in your career it was hard to spot how all these things can add up.
Yeah. And you're touching on something there that's so important. It's that idea of the broader context, you know. And as you mentioned there, you know, actually in that specific story there about his client with the stress fracture, you know, he'd had a previous stress fracture, and he'd gone to a dietitian and done loads of hard work on trying to, you know, improve the factors that we know are associated with sort of bone stress injuries. So it was kind of hard for him to hear again that he'd a you know, a bone stress injury. But when we drilled into it, you know, he's got a newborn baby, and sleep's not good, of course, you know, and, you know, we can often just maybe miss these things that are there, that if I'm suddenly sleeping, you know, 4 or 5 hours a night and I'm still training at a high load, well, look, my body just can't recover as well. And I think that's where the kind of detective work and the kind of rapport and the relationship you build with your client is so important, that you're trying to get access to this information that, you know, sometimes takes a while to kind of, for the full story to come out as well. And it can be difficult. And I think a few key questions I think that we always need to ask are, you know, how's your sleep? Because it usually is a good marker for how are you stressed, or how much stress have you going on? Like, if, you know, and how busy you are, and maybe what else is happening in your life. So, I think asking those questions around sleep and around stress and around, you know, kind of life load, you know, is there any big life, you know, events happening at the moment, which of course can be an impact on how our body recovers and how I feel. So definitely, I think really, really important.
Okay, we have our diagnosis. We know let's imagine it's my knee. We know there's something going on here at my knee. I can't run at the moment. I can't squat at the moment. Is that it? Like, is there anything I can do, you know, as part of this diagnosis level on our rehabilitation framework? Are we looking at anything else? Are we, you know, the idea of let's not detrain, let's not decondition at the same time?
Well, Mike, you said it there, you know, is there anything I can do? Yeah. And that's something that I think is exactly the way I would frame it. Let's find out what we can do, not what we can't do here in this early phase. Well, yes, we have to protect the injured tissue. There's loads we can do. We can start by priming your recovery, by giving you advice around the importance of sleep, the importance of nutrition, the importance of stress management. We can also start to exercise the non-injured areas. Begin by loading those muscle groups. So if you have a lower limb injury, can we load the other limb, and can we load your upper body? Can we also get you started on an aerobic program to start working on your conditioning? And I think there's a huge part there, which it can be a big mindset shift, because so often what happens is, you know, I get injured and the rug gets pulled from underneath me, and I now can't do the things I enjoy. And it can have a real effect on our mood and our sort of sense of self as well, a little bit, where, you know, I can't do the things that I have identify with. And it's I think a huge part of it is kind of helping people gain control over that again and get back doing things that, you know, we start feel like we're moving in the right direction. And of course, aerobic training helps my recovery. certainly it's important for my overall health, and it's usually important if I'm involved in any sport that we start building a base there. So what we don't want is that our injury is this kind of, reason why everything falls off the wagon. We want to be much more proactive than that if we can. As I said, oftentimes like framing it early as our goal here is to come back better than we ever were. So we need to start that now. What are the things we can work on? What are the things we can improve? And I think that's a really powerful framing, and people often leave, I think, energized by that idea when we've mapped that out. And it is important to spend time on that early on.
Yeah, it's that idea of can I make plan B as close to plan A as possible? And like we've both been there, right? We've both played sport our whole life. You get injured when you're fit, you're giving out about training on a wet, cold, night in November, and you're saying, "Oh, geez, I'd love to be staying at home right now, cozy at home." And the second you're injured and you can't do it, that's where you want to be. So it's a huge part of the athletes come into us, or even the older person playing a bit of golf or going for their walk with their friends. It's a huge part of your life, and when you can't do it, as you said, the mood can drop a bit. So having this really sort of global, all-encompassing plan of, okay, let's not do this, this, and this, but let's definitely do all of this, I think can really help the athlete. And I'm huge on the sort of the science behind this detraining and this deconditioning. And if I'm an athlete and I've spent 15 years building my aerobic base, and the second something's injured, I just do nothing, well, I'm going to start to detrain, at a reasonable rate. Or if it's strength and power training, if my knee's at me and I just say, well, I'm not going to the gym if I can't do everything, I'm going to lose that muscle mass, that power, that strength, again, quicker than I'd like. So, let's lose as little as possible. So if I drop a little bit and we fix the problem knee, I'm coming up from an okay base. Whereas if I let that fall off a cliff, I've a bigger stairs to climb.
Yeah, 100%. And, it's simply like, don't stop. We don't want to stop our activity levels. We don't want to stop training. We want to change our training, adapt our training to suit our needs right now. And that's what we can help people with as physios, but we don't stop. And that's a really important thing. And I think that can be a mindset shift for people, which is really important. Hugely important part of the sort of diagnosis phase is pain management. And, it's one of the most important things for clients and for us too, is that we help people get on top of pain. What works for you, Mike?
Can depend on what the injury is, what the diagnosis is. So, the old sort of RICE, or now it's the police protocol. Do we need to protect this site? If I've rolled my ankle or I might have had a fracture, do I need to offload it? Do I need to tape it? Do I need to mind it? Do I need to go into a sling for my shoulder? Is there a lot of swelling? Does it need ice, or is it well left alone? Do I need anti-inflammatories? Do I need painkillers? Do I need to sort of offload or protect? That can help. Sometimes actually by doing our initiation, which we'll get to now in a minute, but sometimes by starting my exercises, that can really help for my pain. If this long-standing knee pain when I walk down the stairs and my knee goes forward is difficult, and my quad is really weak, and sometimes I give someone a quad exercise or a knee exercise and they feel really good after, I say, well, actually, that's your painkiller. This exercise is your painkiller. You're going to feel better after you doing this, more so than after taking your anti-inflammatories. But we're trying to get to, I suppose, what kind of pain is this person coming in with? Is this a bog standard muscular pain? Is this a tendon pain? Is this a bone pain? Is this some sort of neuropathic pain? Or is this, something way more complex, a more centralized pain, or, a complex kind of pain presentation? So, it's part of our accurate diagnosis is to figure out, is there a structure involved here? Is there a particular type of pain involved here? Have I seen this in the past and I know I can help them, be it with modalities, be it with ice, be it with electrotherapy, be it with medication, be it with exercise? How can I get that person feeling better? And if you can get that person feeling better, within that first session or ASAP, they're going to really trust you, and they're going to hopefully follow the plan from here on out to get back to where they want to go.
Yeah, no, spot on. And I think it's such an important area. And I think, the kind of the management of pain in kind of the physio world has progressed quite a bit. You mentioned we have our RICE protocol. And I think a lot of people are still stuck on the RICE protocol. You still hear it mentioned a lot. And then you have your police protocol, and even more recently you have your peace and love protocol. And it's just been really interesting to see how that actually develops over time. And
I think they developed that in Woodstock.
Yeah, I like the name of it. But I think there's so many areas to this, and I think in the clinic here, a huge part of what we do, I suppose, around pain management is advising people, first of all, advising people to maybe avoid things that aggravate them, try and help them identify the things that aggravate their pain, whether that's an activity or maybe a total amount of load, or how frequently they're doing things, and to open up the door to ways to create the conditions for them to feel less pain, which often is focusing on things like recovery, optimizing sleep, getting their nutrition right, managing stress, and just taking some relative rest away from, stressors that may be activity related, or it could be more life related. And alongside that, it's exercising the body in a way that is therapeutic. So it's showing someone exercises and movement that helps their pain. And again, that can be very simple, and sometimes it's a little bit more in-depth and complex. And that our skills there and exercise selection are really, really important. And why does exercise help? Well, I suppose we get increase in blood flow. We get warming up of that tissue. We often get we get pain inhibition often. And when we exercise, we can fire those muscles up a little bit better. They become less inhibited and then start to function a bit better, which can often make the joints that the muscles surround feel a lot better. And we also get a greater sense of, self-efficacy. I can actually do this, and maybe I've been avoiding this for a long time. And our bodies are built to move. We're healthiest and happiest when we're mobile, when we're active. So if we are inactive, well, we can sometimes be using that as a coping strategy to reduce pain. Ultimately, getting you back active and moving is really important for reducing your levels of pain and restoring your function. So I think they're all really important. And then our skill set as manual therapists can come in here a lot, whereby we can facilitate people moving better and feeling better with some hands-on therapy. That can be some soft tissue work, sometimes some joint mobilizations. So this can include, massage work or mobilizing a joint. And I really like to combine this with exercise so that we use the soft tissue based work to facilitate giving someone exercise that also makes them feel better. Because I think it's always about empowering people to be able to make themselves better, rather than having it too much so that they need someone else to make them feel better.
Yeah.
And that's really important.
And I think though, we almost need to check ourselves on this pain side of things, that this can be really, really scary for the person in front of you. And, while we might have seen 1,000 shoulders and 1,000 knees, this person's coming in, they're not booking into us for a laugh. They're booking into us because this sore knee is actually really affecting their life. And maybe they're really, really worried about this, and they might have seen a couple of people before us, and they have a neighbor who had a bad knee and couldn't play golf anymore. And now, maybe their own sense of community or sense of, I suppose, normal everyday activity is being affected here. So this can be scary. It can be worrying. They're not booking into us. And again, for like our diagnosis might be weak rotator cuff and asymmetrical loading during certain exercises, but they're not coming in saying that. They're not saying, Richard, I think I have a weak rotator cuff and asymmetrical loading. They're saying that I've pain in my shoulder, and pain is the main driver. Pain and injury are the drivers of people booking in, and we don't want to gloss over that and ignore that and just jump straight into this. What you need to do, it's what actually explain the pain, explain why it's there, show them this movement's sore, this one isn't, or that one isn't.
Yeah.
We'll get to that initiation phase in a minute, but, hopefully if we can initiate the right exercise or the right protocol or the right pain management and they feel better, that's relief. That's fear dying down. That's maybe I will get back playing tennis with my friends and go for a coffee afterwards because I'm really meaning that, I'm really missing that. Or maybe that is I can get back on the pitch and play GAA or rugby or soccer or whatever it is, That's my group and I've been training for years and the big finals coming up. So we can't gloss over that pain side, because that's often the biggest thing that they come in saying to us.
Absolutely. And I think an important thing to always try and help people with is, first of all, just empathize with them and to listen to them and to validate the feeling around pain that they have, and to acknowledge the stress that can come with that, and the impact that can have on someone's quality of life, as well as their identity and their ability to do what they want to do. I think that's really important, absolutely. And I think, there's probably, different ways in which we deal with pain, and maybe different types of pain that are really, really important, as you touched on all the different types of pain. And one of the important areas, I think, for us is trying to help people understand what their pain means. Does this pain mean that you need to stop? Does this pain mean that that every time you do this thing, you're damaging yourself? And quite often, pain doesn't mean I need to stop, and it doesn't mean that pain does not equal damage. They don't mean the same thing, but there of course can be a relationship, and is a relationship between pain and injury, but they are not one and the same. So sometimes we have pain that is trying to protect us, and it is guiding us maybe to become less active and to change our behavior. And part of us is to try and work with that pain to help people try and find a way forward and find a way to improve and, of course, reduce that pain and improve it. And depending on the length that the pain has been there, etc., there can be a very different meaning behind the pain. And it's a detailed area that we will often spend a huge amount of time with our clients. And I think one of the things we have expertise in is dealing with those maybe more complex pain scenarios. And it's probably for another chat to go into the details of it, but it's certainly an area that is it's really important, I think, for people in persistent or chronic pain that they're listened to and that they're heard, and that they have a support there from therapists that can help them. And certainly something that we enjoy working with and that we can often see big progress with.